Hi, and welcome to episode 12 of How to Beat Nick. Today, we're going to be talking about health and the health insurance industry. When you talk about healthcare debates, it's important to bifurcate the debate into the three appropriate hierarchies of healthcare. So the first and top one is health. Health is a measure of a society's healthiness, right? It's how sick you are versus how healthy you are. People think that things like pandemics and diseases are the primary mechanism by which societal health is measured. That's generally not true. The strongest causal links into declines in societal health are demographics. So, for example, in Japan, an elderly population is far more vulnerable to health issues than a younger population, and just most saliently, objectively, poverty. Right? People that are poor are very often malnourished. They're incredibly vulnerable to health issues. So when you ask the question of health, it's usually far more linked to the economic circumstance of the country than that country's healthcare system to begin with. The second layer of this debate, so there's health, and then there's health care. Health care are the people who provide health care to consumers. So these are hospitals, these are doctors, these are pharmaceutical companies. These are not health insurance companies, which don't provide healthcare. They actually pay for healthcare. They're purchasers of healthcare. Healthcare providers tend, somewhat ironically, to not always care about societal health. In public systems, like with the NHS, they do, because the NHS is just a cost, and a healthy society would incur lower healthcare costs. So societies like Great Britain and Canada very often consider investments in things like public health. America doesn't do that. We don't cure diseases for the most part because it is very often far more profitable to simply prescribe long-term treatments for the symptoms of those diseases. So this distinction between health and healthcare makes it very difficult for policymakers to pass things like anti-obesity regulations or better nutrition in schools, because in many instances the healthcare industry, who have the most proximate economic interest and the most compelling lobbying interest, tend to want society to be more unhealthy, because a more unhealthy society is how they pad their bottom line. The third actor in this tripartite drama are health insurance companies. Health insurance companies are not healthcare companies, although we'll get to vertical monopolization at the end of this lecture. Health insurance companies take money from people and purchase healthcare with it. And so they do this through a couple of mechanisms, right? First, you buy health insurance, that's great. They then negotiate with healthcare providers to get a good deal. So for hospitals, right, they have in-network, out-of-network. In-network just means they've pre-negotiated a good deal. They will punish consumers for going out of network, usually with much higher copays. They work with pharmaceutical companies. So they work with these things called pharmaceutical benefits managers, or PBMs. PBMs are the middlemen of pharmaceutical pricing. So basically they get the insurance company and the drug company to agree on a middleman price, and then they go from there. PBMs exist for both private insurers, and they exist for the biggest insurance company in the world, which is Medicare and Medicaid. So you have to understand all of these layers of middleman interaction if you want to be able to effectively make arguments about healthcare and the health insurance industry. Notably, any normative debate about healthcare must implicate its arguments to health, because it actually doesn't fucking matter like how much money healthcare providers make unless they then use that to provide health to their customers. It doesn't matter how much money insurance companies make unless they then use that to provide health. The reason this is particularly relevant is the kind of iterative nature of this process and the entangled nature of this process means that almost every policy that's theoretically designed to do something has the potential for having a backlash effect. One of the best examples of this is just like, should uninsured people be allowed to seek emergency room treatment? And the answer in like intuitively should be yes. They are unhealthy. We can give them health. Health is good. Unfortunately, emergency room treatments are incredibly expensive, and uninsured people tend not to pay. So the healthcare company, in this case the hospital, has to pay that out of pocket. If that hospital is operating under low margins, and many are, and if specifically the emergency room is not profitable because so many of the people coming through the emergency room are not paying and their insurance is not covering them, hospitals tend to shut down their emergency rooms because they just can't afford to keep losing all of this money on a loss leader, which happens a lot. And that leads to a decrease in health because it would be far better to have a semi-operable emergency room that did turn away some patients than to have no emergency room at all, forcing people to seek alternative mechanisms of care. The same is true of really any case that involves entanglements with the insurance industry. Generally, the insurance industry is the most powerful actor in this debate. One, because they have the most money. Two, because they lobby the governments the most. And three, because they've engaged in vertical corporate monopolies with healthcare providers. So Blue Cross Blue Shield owns hospitals. Should that be legal? Fuck no, but it is. And, Aetna owns Cigna and whatever the fuck. All of these companies have basically done vertical monopolies. So their in-network hospital is owned by the same guy that's providing the insurance. Understanding this cyclicality, whether it's insurance company, hospital, patient in healthcare, or with drugs, it's insurance company, pharmacy benefits manager, drug company, pharmacy benefits manager, and then the pharmacies that are distributing these drugs or the patients who are receiving these drugs. Understanding the cyclicality of these three layers is critical to constructing any robust argument in a healthcare debate. And without it, you really have no chance in hell of winning any round.